What a cloudy day today. Wow.
Good morning, Rob.
Good morning, Mark. Good morning, everyone out there. We're connecting with everyone for our April OMD Talks. And as we do every month, we try to take some questions that we were asked from our patients, from you guys, and from also that we find we're talking a lot about in the hygiene rooms or in new patient consults or for current patient consults who have issues that we need to address. So the one thing that we found happening so often, and a few patients asked us about this, was about orthodontic treatment and what are the benefits of it beyond just the physical appearance of straightening your teeth. And so when we're talking with our patients frequently about orthodontic treatment, many of our patients assume that it's for cosmetic reasons, but there's a lot of health benefits.
100%. I mean, a lot of people think orthodontics are just for children, and it's not the fact. Again, we're not just doing it for aesthetic reasons. Orthodontics are done most of the time these days for health reasons, to properly align the teeth better. You know, people think that they're coming in, we're sending them for an orthodontics for braces, and say, why do I need braces? You know, I didn't do them while I was a child, or I do it now at this point in my life.
I guess what happens is an issue with people's teeth are crowding. As we age, there's something happens, right? So we have wear on our tooth to tooth contact from your upper lower teeth contacting, but then you also have wear from the tooth next to each other contacting because they're moving.
And then they're more prone to shifting, right?
Right. So your contacts are wearing, and our teeth, some reason they shift and migrate forward and crush together and kind of get crowded.
Most of the time you'll notice that in the lower incisors, right? Because everything gets pushed forward. The lower incisors have the narrowest roots, and they're more prone to twisting and moving. And you'll notice it when you go to floss your teeth. You'll find there's more spacing between your teeth from the shifting of your teeth.
And then there's more spaces posteriorly, but yet anteriorly it becomes tight.
Crowded. So the conception is everything is moving forward, right? As the bite wears down, as the lower teeth move forward, you may also notice the upper front teeth will start flaring out forward from excessive pressure. So how does this come into play with we do? You know, we're not orthodontists. We don't do orthodontics. We'll refer it if it's needed, but this comes into play if we're doing some restorative treatment, whether it be crown restorations or veneer restorations.
Right. So I guess straightening teeth compared to teeth that are crowded, there's some benefits and some problems with crowded teeth, right? And so you mentioned there when you're flossing, there can be some issues. So crowded teeth are harder to clean.
Right. So crowded teeth, there's less gum tissue between the teeth. The root proximity is closer. Like you said, they're harder to clean, harder to floss in between. Let's talk about the health benefits of orthodontics.
Yeah. So you and I jump into the most frequent thing is your teeth are only as healthy as the foundation of your teeth, your gum and bone tissue, right? And when teeth start to crowd, food, bacteria, calculus tartar accumulates around the teeth more because things are getting caught in those spaces and they're harder to clean, right? How often do you see a patient in the hygiene room and they're crowded teeth and there's just so much buildup in those crowded spaces?
I would say most patients who have not had orthodontics has some variation of crowding of their lower incisors. Not all of them need orthodontics. Some is worse than others. But yes, there's a variation of crowding on most adult patients.
Right. So it's harder to clean for you as an individual at home, which from flossing and brushing, because the brush can't get into those spaces, right? However long your brush is longer than the little spaces, the irregular spaces between your teeth, right? So the brush just can't get into that space. And then the hygienist has to spend more time because there's more inflammation, there's more buildup, and probably more recession over time. And the thing you talk about with your patients is then you also are losing the space between the roots. So as we call it root proximity, you're losing the bone between the tooth also because the roots are getting closer to each other.
So the more bone we lose between the teeth, now we're jumping ahead to possible tooth loss in those areas.
We find often in our practice with our patients, isn't it? We find patients that are 70 and over that are having a lower tooth or lower teeth that are compromised. And this is something we talk about a lot.
Probably in the older population.
70, 80, 90.
You'll see the first tooth loss in the lower incisors, right?
Yeah. And that's because of the crowding, the lack of cleaning, and the root proximity. So I feel like it's almost at least once a week where you and I come to each other or one of the other docs in the practice. It's like, what do I do here?
Do we take one tooth out and now the next tooth is eventually going to come out? Do we take both of them out? And then it could seem a little aggressive taking the 4 lower ones.
And then you're going down the rabbit hole.
And sometimes that's more of a definitive plan.
And this could have been prevented by orthodontics.
100%.
Right. So from a health standpoint, forget the aesthetics, there's a huge win with straightening your teeth. And the earlier you do it, probably the better.
We're concentrating on the lower incisors because thinner roots, those are usually ones that flare first, that we say. But the upper maxillary ones are going to go in conjunction with that. As the lowers move, the uppers are going to move along with it.
And then as these teeth are shifting, aside from going towards the root surface, also their relationship with the tooth above it or the tooth below it. The other thing that we're spending every week, you and I spend time on with our patients, is fixing chipped front teeth.
Lower front teeth, yeah.
And upper front teeth. Right.
As the teeth move forward, the bite changes. There's more occlusal force, there's more contact on the front teeth than the back teeth, and the edges wear. And like you said, the thin enamel edges start chipping, and patients want us to just put a little bonding on there, which is not going to be stronger than the enamel that just wore away.
Yeah.
So then do you crown the tooth to get more coverage on there? And again, you're going down that rabbit hole. You're doing some maybe restorative work where you should be doing orthodontic first to put the teeth in the proper position first.
Yeah, so if you think about it, your teeth are shifting and something has to give. They just shift. They compress, they rotate. And what gives from that shifting is the brittleness of your enamel and tooth surface, and it just gets out of the way. As things start to shift a little bit, the tooth structure's in the way, it starts hitting differently, and then it just breaks. And then Mark and I find ourselves, and everyone in the practice finds ourselves sitting with a patient, and we're talking about what to do about this because we repaired it once or twice or 3 times, and now it's a chronic issue. It's annoying for everyone involved. It's unsustainable. It doesn't look good. Doesn't feel good. It happens on a Friday night at dinner or whenever it is on vacation.
And once those lower incisors chip and we repair them, it's usually going to recur again.
I had a patient this week look at me. She's 75. She's crowded, and her teeth are in a really bad position for one another. I'm talking with her about orthodontic care. And she's looking at me like I'm crazy. I'm 75. I should do braces at 75. Well, but you do Invisalign, not braces. But do you know the oldest patient you've had do orthodontia? I know for me, they're in their 80s.
That's impressive. That's great.
Yeah.
I would definitely say in the 70s. I'd have to look back and look.
I know I've had an 82 to 83-year-old do Invisalign.
Yeah. It's impressive. As long as the bone is there and the teeth aren't loose, it's a viable treatment plan. I've had patients come for restorative dentistry and their teeth are all over the place. I've corrected them with orthodontics and not have to do restorative dentistry.
There's a cosmetic dentist. This is a perfect segue. A cosmetic dentist who posts a lot on social media. And within the dental community, there's a lot of talk about how they put restorations on teeth without correcting the positions. They treat teeth that are malaligned, crooked, and they put these restorations on that have the bodily shapes that do not mimic what's biologically in your mouth. They look pretty good.
From the front, they look like they're lined up nice and straight.
But when you're creating spaces for bacteria and food to harvest that are not exactly hygienic, you're setting someone up for potential problems. Now, I'm not saying there are problems. You have to track those cases and track their home care and track their actual hygiene regimen. I don't know if they're going every 4 weeks for a cleaning, every 6 weeks, whatever. Like there could be a way that works, but I know there's a better way of doing it for supporting the biology and foundation of someone's mouth, possibly by aligning teeth.
Yeah, so stop for a second. So what you're saying is you could look at these person's teeth who've had cosmetic result, maybe 10 veneers, and they could look nice and straight and pearly white. Now you look at those teeth on the x-rays and you see this tight root proximity. The restorations are too tight together. There's no space for the tissue to heal properly between there. And it causes more of an inflammatory response. And the restorations are not going to last as long because of that.
Right. So there are 2 reasons that stand out why to do orthodontics before restorations. You want to change the way your teeth look, or your teeth are breaking down. They could be wearing, like we were talking about, chipping. They could be wearing from the inside that you might not be able to see as much, but the enamel could be worn away. So the first reason to do orthodontics before restorative care, like you said, is the health, getting teeth in the right position so the restorations can be the right shapes to set someone's mouth up for biological success.
Yeah, so that's going to improve the health and also improve the aesthetics at the same time.
And the second reason is the functional health of the teeth, right? Putting teeth in a better position will allow for forces to be controlled better. I had a patient recently who had wear on the inside of her teeth, suffered from acid reflux, and she wore away a lot of the enamel. And as she did that, the teeth were shifting and there was no room available. There was no room available between the lower teeth and upper teeth. And so we had to make some room, because if I were to restore those teeth and protect them, I'd have to drill something away.
You'd have to be so much more aggressive preparing the teeth.
Yeah. So it's like, do you drill away the lower teeth? Do you indent the upper teeth? And so we decided to do some pre-restorative orthodontic treatment so we can, the most healthy way, cover that tooth without taking any of that away. It was great preparing it and to take any away. It was really nice.
Well, take for an example a patient who has an upper tooth that is flared out, maybe 3 or 4 millimeters out of the arch. To do veneers on that case, really have to aggressively prepare that tooth to bring the tooth into the arch more. Where orthodontically, if you set the teeth in place, there'll be a lot less preparation, a lot less drilling on the teeth if the teeth are properly aligned before restorative treatment.
Yeah, don't you find the hardest thing to overcome here is the patient's will to do the orthodontic?
Yeah, because I think it's more the time commitment is the concern. They want a quick fix, and they don't realize that the restorative treatment that we do, if it's done properly, could last them 20 years, the rest of your life, right? So without the orthodontics, that 3 months, sometimes it's only 3 months or 6 months of orthodontics, that's going to reassure
It's an investment
that the case is going to last a lot longer.
That's a lot longer. The treatment's going to last a lot longer. It's going to cost you less time in the chair, less money, and actually keep you healthier longer.
I think it's the time. Most people get held back on the time restraint of orthodontics. They think they're going to be in braces for quite a while. They're not going to be able to speak. I think that's the hesitation that I find.
I had a young patient who just started orthodontic treatment, and he texted me. He said, okay, I'm going through this treatment, and my buddy at work said I should be doing this at home only during the night treatment that is quicker and better than what classical Invisalign is.
Moving the teeth just at night.
Yeah. I gotta show you this. Text had changed. I gotta show you this.
I wish that was possible.
And I asked him, what are your friend's credentials? He was like, it was a joke, but we got into how tooth movement occurs and setting up for success and the compromises that you have to accept by doing it shorter time and not wearing the trays and everything. So, an investment in time, it's like 8-minute abs versus actually working out for real. You're going to be a lot better place if you go about it the right way from the beginning.
Also, it could be detrimental if you're moving the teeth just at night and then they're moving back into place during the day. It's the rock and motion where you're taking bone away from one side of the tooth and it's not filling in on the other side. The teeth can actually become looser. So like you said, it's not the quick 8-minute workout. It's the longevity, being consistent with the orthodontics.
And the other thing we didn't touch upon, and we won't go too deep in this, but also that orthodontics can improve your ability to take in air. Volumetrically, there are people who are getting more and more patients. It's more on the radar of their physicians about sleep issues and snoring and sleep apnea. And a lot of these patients are crowded. They may have had premolars out when they were teenagers, children, getting orthodontics to make room for teeth. And instead of opening the palate, they kind of condensed everything. It was common practice 20, 30, 40 years ago. And so there is a benefit for a lot of our patients and the ability to take in air volumetrically by the right orthodontist.
Well, it's a larger benefit these days for children to see an orthodontist at a younger age than they have in the past.
2-phase ortho opposed to 1.
So where in the past you would do orthodontics in your early teens, where now they're being seen at 5, 6, 7 years old for possibly expanding the palate to make room to open the airway. So I think the future of dentistry is we're going to see less crowding if it's being addressed at a much younger age. As Rob said, 2-stage orthodontics, expanding the arch if needed.
You're actually expanding the palate.
So expanding the palate is expanding the arch at the same time a little bit, and then you're treating the teeth.
The first phase when you're 6 and 7, you're treating the bone. And then when they're a teenager, then you treat the teeth. When you're a teenager doing 1 phase of orthodontics, you can mostly only treat the teeth.
Correct.
You can't really move the bone. And that's why there's 2 phases.
So by moving the teeth without the bone, you're really not setting up for the best angulation of the roots. And you're tipping the roots a little bit, where if we expand the bone, the whole palate, the whole arch will widen at the same time.
Well, that brings us to our next point that a couple patients emailed us about from last session and talking about dental implants. What are the implications of dental implants, and what happens once you get an implant? What are the things to think about?
Why do I need an implant? And people ask, oh, why do I have to replace the tooth?
An implant is a titanium screw that replaces your root, right? I find that most patients are really understanding what this is for, a lot of reasons. I mean, do you understand what a knee replacement really looks like? No. So if you think about this titanium screw, it goes into your bone, and it has a few different textures on it depending on the implant that your surgeon buys to put in your body. It's coarse, treated titanium that allows the bone to grow into it. So it has to be textured, and it has to have these nooks and crannies for the actual bone cells to grow into it and lock it into your body. And some of them, the part that just comes out of your mouth is polished and really smooth, and that allows your soft tissue to go around it and also reduce bacteria.
Also titanium.
Right. It's one piece. And then the tooth part, which is a combination of titanium and ceramic, is what you see visibly in your mouth. And there's transitional zone. And so there are some implications of how you take care of that, because the size of the implant is typically different than the size the root was before.
Correct.
Where the tooth is the same size. The tooth in the tooth before and the crown you have now is the same size, but the supporting structure is more narrow.
So that's going to vary also where in the mouth the implant is placed, right? If it's a front tooth, an upper front tooth, the implant is going to be relatively similar to the shape of the root that was there, as opposed to replacing a molar that can have 3 large roots. Now we have one thin implant going up to a larger tooth.
An implant's about 4 to 6 millimeters round, where the tooth is like 10 millimeters round. And circumferentially, you had a rectangular shape to a round shape.
Exaggeration of that is kind of like a lollipop, right? A thin stem coming up to a larger tooth. And that's more of a problem in the molar area, where we have a larger tooth with a thinner implant.
That's a perfect analogy. When you're flossing, your home care of an implant is different than on a tooth, right?
Just like this mirror, right? If you look at the implant compared to going up to the tooth.
Yeah, so the implication is most importantly how you floss. Like, you need to floss your implants or clean between them somehow. So with a tooth, you're going more vertical. Angular vertical, right?
Correct. An implant, you're coming underneath the crown, running along the gum.
Yeah, you're almost going parallel to the teeth to perpendicular then, right? You're going underneath, you're tucking underneath the implant back and forth. I find that a lot of patients aren't aware of this. They've had implants, no one ever talked to them about that. That's why it's a good topic to talk about. And especially over time, implants are subject to the same issues periodontally that your teeth are. Bacteria infiltrates. There's no ligament on an implant, so there's a little less resilience possibly than your teeth had. So if you do get some exposure of that textural titanium component, more bacteria can stick on it. So if anything, the implication of having a dental implant is you have to take better care of it than your tooth.
Yeah, flossing may not be the answer.
Flossing alone.
Correct. Just flossing and brushing alone. I mean, we have little proxy brushes that will go in between, little bristle brushes that come in different sizes depending how much space is between the implant and the tooth adjacent to it. So these larger brushes will go through at the gingival level, at the gum level, and be able to clean along the side of the implant and the adjacent tooth. It's more the adjacent tooth that we're worried about also, right? Is plaque sitting on the adjacent tooth and a cavity forming between the implant and the adjacent tooth on the adjacent tooth.
Yeah, we see this a lot in our practice, and there are some studies that have been done around it. Not a lot have been out, though, about decay starting on teeth next to implants. And the nice thing about this conversation that we had today is that it ties together because teeth are shifting, right? So over time, let's say you have a posterior implant, and as we've spoken about previously, your teeth can shift as you age. And so they can shift away from the dental implant, creating these spaces where more food can get caught and then decay.
And the implant will not shift, right? Because the implant's integrated in the bone.
Yeah. The lack of the ligament causes the static. It's a static object in your bone where your teeth are moving. And so you're subject to gum disease, periodontal disease, or peri-implantitis on the implant, also on the tooth in front of it, and decay. The implant cannot get decay, but the tooth can. So we see a high rate of this happening, teeth shifting and people with implants and having to deal with these problems. And so, I mean, look, if you didn't replace a tooth, that's not what we're saying here, just to be clear. It's like...
No, because there's implications of not replacing teeth. You get that question a lot also. It's a back molar. Why do I need to replace it? Why not? If there's any other body part that you lost, you would try to replace it.
I guess, how do you think about that conceptually? I guess there are people at a certain point in their age where replacing a second molar doesn't matter, depending on the bite.
I look at 3 things. I look at health, age, and the patient's financial means. right? And if you're healthy and there's no medical compromise, no medical history that's compromising the implant, patients that are on blood thinners, that doesn't mean you can't do an implant, but it's a little bit more of a compromise. As long as the health is managed, age is not that much of a factor. It's more of a factor, I think, if you're younger.
The only real factor medically why where dental implant success really changes is diabetes. Diabetes is really the only real health condition that impacts the success of dental implants. We haven't found another thing. Even smoking doesn't reduce it as much as we think. Smoking drops 1%, where diabetes can 5 to 10% drop on success rates, that is.
And same with most medications, even the bisphosphonate drugs that people are alarmed about. It's 0.1% failure of people, of implant failure with people on bisphosphonate drugs. Like we get back to age, it's maybe if the patient is too young, if you lost a tooth at a younger age, and the patient's arch isn't fully grown, you may want to wait and do something more conservative before an implant is placed.
Yeah, in our practice, we don't like to consider implants on people younger than 21 years old.
Pretty much, right. But there's really no age above that. You said you've had a patient who was 85 doing orthodontics. I would certainly be comfortable doing an implant on a patient of that age. And
it's a philosophical conversation about how do you want to treat yourself and your body. We don't know for most people when they need the implant until. I don't know how long you need your teeth for. If you don't know that answer,
yeah,
what are you managing for? And I guess we happen to have to represent our patients philosophically on what they think is right for them at the point where they're at in their life. So it's a challenging decision to make. So as Mark said, if there's not a major health or financial issue, we generally support it because not many people regret getting something fixed that's going to then support their health. And the reason is that as you lose teeth, your other teeth still have to do the same amount of chewing and functioning.
Or more now, right? More stress on the adjacent.
We do see a further breakdown on teeth when people start losing teeth and not replacing them. The remaining teeth start to break down faster. And so now we end up going down this situation that, well, if we would have replaced the implants or replaced the missing teeth 3, 4, 5, 6 years ago, we never would have been in the situation we are now. Now you're 6, 7 years older and things are more complicated. And now we have to deal with it. We have to deal with it.
Correct.
So sometimes I don't think we're trying to convince people, but sometimes we're trying to explain to people the benefits of getting something that's simpler and easier now and more supportive of your health that you can't exactly appreciate until you get 10 years down the road.
Yeah. Could cause less complications in the future.
Yeah, these things in healthcare are hard to measure. We're talking to a few of the docs this week about how a patient can understand outcomes and the way we do things here in our practice and taking more time for treatments and using the best materials possible, having fantastic ceramics and wonderful assistants. And every step along the chain of fabricating something for a patient, we try to make sure we're doing it the best, most right way possible. And how when you get there versus if you do it with compromises in a shorter way, you can't exactly appreciate the outcome on day one. It's a challenge in healthcare. It's a challenge.
Yeah, you may not find out for years later.
Right? Getting something done today, you can't say, okay, well, yeah, I can measure this is going to last me 20 years versus 7 years, so it's greater. You don't know that until it's the 7-year and 20-year mark. So it's challenging. So I think that just as we wrap it up, just something to think about philosophically and how you're taking care of yourself and how the people who take care of you are handling that process. I know we're trying really hard to handle it as exceptionally as possible. We weigh, we measure what we're doing and we try to figure out how to do it better. So I don't know either, Mark. All right. Well, hope you're having a great April.
This was great. Please send us some more questions for future topics. Right?
Yeah. Send us some more stuff for our May talk as we start to get through spring here. It's looking beautiful in the park. Look at you see the buds happening. So.
The buds are coming out.
Yeah. All right, all.
Very well.
Thank you for your time. Thank you for your trust. We'll see you next time.